Hi, welcome to my YouTube channel, and today I'll be discussing about acute aortic dissection and aortic aneurysm rupture. I'll be putting forward their differences and their treatment modalities and their management, because we often get confused in between these two. So first of all, what is acute aortic dissection? Acute aortic dissection tends to occur in individuals who have chronic hypertension. That's the first main differentiating factor from abdominal aortic aneurysm. Okay, so acute aortic dissection occurs in individuals who have chronic hypertension or who have any connective tissue disease like Marfan syndrome, or if they are on cocaine or any substance abuse that increases the amphetamine activity, causing hypertension. So the basic risk factor is chronic hypertension for acute aortic dissection. Okay, now how will a patient present in acute aortic dissection? They will present with sudden tearing chest pain that will be radiating to the backside, and differences in between systolic blood pressure of both the arms. The patient will be already having hypertension, and then there will be a significant difference in between the left and right arm for the systolic blood pressure. Okay, and on chest x-ray you will see mediastinal whitening, and so these symptoms are suggesting aortic dissection, right? So aortic dissection, you know that it is defined as an intimal tear in the tunica media or intima, okay, and that would cause the blood to create a false lumen. So that is when aortic dissection occurs. Now, as I have presented a person's situation that he's presenting with severe tearing chest pain radiating to the back with high blood pressure and blood pressure variations in between both the arms. So what is the best initial step? They say that what is the best initial step? That would be chest x-ray. If they have already mentioned that chest x-ray showing widened mediastinum. So now what is the next step? Next step is CT angiography, which is the diagnostic test. Okay, so if they ever ask you what is the diagnostic test, it's CT angiography or trans-esophageal echocardiography. Okay, so it is either one of those. Now, CT angiography is contraindicated in patients who have renal failure or who cannot tolerate contrast, who are allergic to contrast. So then they can go for trans-esophageal echocardiography or maybe MRI. So this is how you're going to diagnose aortic dissection. Now, after diagnosing aortic dissection, you need to see that whether it's type A aortic dissection or type B aortic dissection. If it's type A aortic dissection, it shows that it is ascending aortic dissection and it requires emergency surgical repair. But if it's type B, it still requires monitoring and blood pressure control unless it gets complicated. So type B is descending aortic aneurysm. It just requires blood pressure control and monitoring unless it gets complicated. But type A ascending, A for ascending dissection, would require emergency surgical repair. Okay, and what can be the complication of abdominal aortic aneurysm? It can be aortic regurgitation that can present with worsening chest pain, hypotension, and pulmonary edema. Okay, so, and you're going to also hear the murmur, so remember that. Now, if we talk about abdominal aortic aneurysm rupture, in this scenario, it's an aneurysm that is going due to what risk factors? The risk factors are completely different here. It's a male gender, age 60 to 75 or more, and smoker. Smoking is the most important risk factor in abdominal aortic aneurysm rupture. Now, what will be the presentation? They'll say that a 76-year-old man who is a chronic smoker or with a chronic smoking history presents to the ER with sudden onset of abdominal flank pain and a pulsatile mass. Flank pain, abdominal pain is radiating to the back and also has symptoms of limb ischemia. So these are the symptoms that the patient will present with. Sudden onset if the abdominal aneurysm rupture, okay, aortic aneurysm rupture. So he will present with sudden onset of severe abdominal flank pain going to the back with flank ecchymosis, okay, and pulsatile mass observed in the abdomen. okay, and limb ischemia because it can cause distal embolization. So what's the best treatment? Okay, like what's the best initial step for seeing it? So the best initial, if someone presents to you who is hemodynamically stable with this situation, so you're gonna go for CT scan of the chest, sorry, CT scan of the abdomen with contrast. Okay, so if someone presents with abdominal aortic aneurysm rupture symptoms, you're gonna go, and it's hemodynamically stable, so you're gonna go for CT scan of the abdomen. Okay, if the CT scan of the abdomen confirms that the patient has rupture of abdominal aortic aneurysm, so you have to go for emergent repair. If the patient is hemodynamically stable, so firstly you need to stabilize the patient, okay, and then you're gonna assess, like you have to stabilize the patient. Okay, so for no known abdominal aortic aneurysm, like hemodynamically stable patient, you do not know that he has that history, so you're going to go for focused abdominal ultrasonography, where you're going to detect that if this patient has abdominal aortic aneurysm, and then you're going to go for urgent repair. If he already has a history of abdominal aortic aneurysm, then you have to just you have to just go prepare for urgent repair. And secondly, if a patient, okay, now what are the indications for elective repair? If a patient is asymptomatic and has an aneurysm growing for more than 5.5 centimeters, if the patient has an aneurysm that is growing for more than 0.5 centimeter in 6 months, or if a patient having abdominal aortic aneurysm also complains of peripheral artery disease or presents with peripheral artery disease, in that way you have to prepare for elective surgery. And I also want to just give you a quick treatment recap for acute aortic dissection that was due to chronic hypertension, right? So what you have to do if someone presents with severe tearing chest pain radiating to the back and variation in hypertension, so you have to first give them morphine for pain, then intravenous beta blockers, labetalol and esmolol. Esmolol is first, so esmolol, labetalol, to prevent the aortic wall stress that is due to shear stress. And you have to give sodium nitroprusside if systolic blood pressure is more than 120. And for ascending dissection, you have to go for emergency repair. Okay, so here we conclude both the differences. What are the strategies to approach both these situations and how different the risk factors are? I hope this helped you, and if you have any questions, please drop it down in my video. I would love to help them. Have a good day.